Very good. So, actually, I had another HIV lecture that I used to give, but it's more of for fellows and HIV clinicians, actually. For you, particularly as a resident, you know, a lot of times you see HIV patient, and then what do? You just refer them to an HIV doctor, and then you don't follow them. So, really, the nitty-gritty of HIV management is not going to be the big of an importance. And so I will try to concentrate on things that will be more of importance to you guys. When you talk about HIV, really, as a physician and as incoming physicians, we really have to take pride on ourselves, really. In the last 25 years, what has been done in HIV hasn't been done actually in any other disease process in our in the entire history of humans. Do you know who Dr. Fauci is? He's one of the premier authors of internal medicine, so he's still in the same position, head of NIH for infectious disease and immunology. So the conspiracy theory always is there. They think that he has an answer in 1980s, and that's what they're saying here. But this is a disease that was just came to the forefront in 1981 with just one or two cases of what turns out to be a PCP pneumonia. At the time, we didn't know how it came to be, how you acquire this infection, and then in a very short time, we found out what it is. We developed a very sophisticated test to diagnose this disease, and then after, we developed actually treatment for it, and this is now a chronic disease. For those of you who don't deal with HIV on a daily basis, I have to tell you that if there was a choice to choose between chronic diseases, HIV should be your number one to choose in terms of outcome. The outcome for an HIV positive person at age, who has been diagnosed at age of 25, his life expectancy with treatment and undetectable viral load, which is very easy to achieve, is less than a normal healthy adult just by 1 year. And how often do we see them? Once every 6 months. How many pills do they take? At most 1 or 2. So really, this is a remarkable achievement. All this success started around 1996 when the protease inhibitors were approved, and that is when we started to use the cocktail regimens. So as you can see, deaths plumped down at that time as the use of protease inhibitors increased significantly. So now we don't give monotherapy, we don't give dual therapy. Everybody has to be on at least 3 medications. The pill count might be deceiving because some of those patients are in 1 pill a day, but the bottom line is all of them are getting 3 HIV medications at the same time. This is actually a picture that really gives you the whole perspective of what this disease is. This is the same patient, it doesn't look like. And the time, how short the time is, between March 2003 and September 2003, this is the difference with HIV medication. So really a remarkable achievement. We don't want anybody to be at this level so that he will be pulled to this one. But nevertheless, if that was the case, these are medications which are extraordinarily life-saving. Right now, we have over 24 HIV medications that has been approved, single medications, and there are a couple of combination medications. So the management of HIV is a specialist area, really, because it's very difficult to know exactly what are the benefits and ramifications of different combinations. The bottom line that you have to know is that almost everybody has to be treated and everybody has to be on 3 medications at a time. So the medications work actually in different mechanism of action. There are entry inhibitors. This is a virus. So the virus has a projection of proteins, glycoprotein 120 and 41. So remember those 2 proteins, because these are 2 of those proteins also that are on the Western blot test when we diagnose HIV. So when you diagnose HIV, you do ELISA test. The ELISA test comes positive. You send them for a confirmatory Western blot test. When you do Western blot test, they are looking for antibodies against a very specific antigens. And there are many antigens from HIV virus for which we develop antibody, but they are not very specific, all of them, okay? So the 3 specific antigens that we depend on diagnosing are glycoprotein 120, glycoprotein 41, glycoprotein 160, and P24 antigen. So if you have 2 of any of those antibodies against those antigens, then that's what a positive test means. So those antigens are here, 2 of them. They recognize the receptors, which are CD4 receptor, and one of the two core receptors, which is CD4, CCR5 or CXCR4. And then there will be a membrane fusion at that time, and the virus will be released into the cytoplasm within the CD4 cell. CD4 cell, as you know, are lymphocytes, subpopulation of lymphocytes. So here there will be reverse transcription of the RNA. So in that process, there are two groups of medications that we have, the nucleoside reverse transcriptase and the non-nucleoside reverse transcriptase. Once it is reverse transcribed, it will be a DNA, and this fragment DNA has to incorporate into the host DNA for it to start replication process. And to get in, it needs another enzyme, which is integrase enzyme, and thus we have another integrase inhibitor. And then once it is integrated, it uses the host's machinery, so to speak, to replicate. And when it replicates and produces its proteins, they come into the cytoplasm, and they will be compiled there and bound and be a virus, a viron, and that is guided by a protease enzymes, and we have a protease inhibitor. Here, at the time of entry, there are two groups of medications that we use. One is that inhibits the co-receptor, which is CCR5. There is one medication, which is Maraviroc, and then there is another one which inhibits the fusion, which is Fusion. So basically, the life cycle has been very well studied, and then the medications really work on those life cycle processes. So one of the things that a resident have to know is when do we start HIV treatment. So basically, because we have been comfortable and much more knowledgeable about the medication side effect and how they work, and also getting much more efficient medications, almost everybody has to be on treatment right now. So the panel had a 12 expert panel, which has been convened by CDC. Everybody agrees that anyone who has CD4 count below 500 has to be on treatment. So there is no argument on that one. Below 500, you be in treatment. Above 500, 6 of them said yes, 6 of them said no. So you take your pick, whichever you decide. So the bottom line is this treatment is so effective and life-saving, almost everybody has to be on treatment. But in addition to that, if someone has a CD4 count above 500, but have hepatitis B or hepatitis C, have renal disease, or maybe pregnant, all of those have to be started on HIV treatment irrespective of the viral load and CD4 count. So this might be something even in a board exam. But with all this success and good news, it's unfortunate that every year there are a lot of new HIV cases being diagnosed. I mean, it's really mind-boggling to know that there are 7,400 cases every day in the world. And within US, actually, we have 54,000 new cases a year. I mean, of course, when you have a viral load controlled very well, and if everybody had undetectable viral load, if everybody who is HIV positive knows their serostatus, this wouldn't have happened, obviously. But that's not the case. So this is where I would concentrate one of the discussions. So if you look at the number of new cases diagnosed every year, since 1991 or so, it has been plateaued. Basically, almost 50,000 cases every year. I mean, it didn't drop a thing. As you can see, it's plain. At the beginning, it was really high, but then after, it plateaued. So if you actually go a little bit into the depths, CDC for epidemiological purposes divides US into 4 corners like this, and we are here in the south. And if you look at the south, actually, that's where the number of cases actually are increasing, and new case percentage is also much higher. We are here in North Carolina. In a given year, we see more than 1,300 new cases. It doesn't mean that they were infected on that year, but they found out that year for the first time. So it's not a small number. If it is a percentage rate, it is about 17.1 individuals per 100,000 that are living in North Carolina. So this is the number of new cases that we have been seeing every year. In 2009, it was 1,600. It's kind of dropping a little bit, but not to the extent that we like to see. And every year, we're seeing almost 1,500 new additional cases to the existing 15 or so thousand cases. In ECU, we cover the eastern corner of North Carolina, east of 95 and northeast of I-40. And we actually cover a big chunk of North Carolina, and we have over 1,000 patients in our Ryan-White clinic. So let's start with the case that we actually saw. This is a patient that we saw a couple of years back here. A 21-year-old African-American referred from ECU Student Health to the ID outpatient clinic for fever of unknown origin. He had a history of fever that started at the end of January, and at that time when he was seen, I think it was February or early March, I don't remember exactly, but he had high-grade fever associated with chills and night sweat, malaise, and headache. There were documented temperatures of up to 102.8 and 103 Fahrenheit at ECU Student Health services. He also had some lymphadenopathy. It was thought to be a fever of viral etiology because they couldn't figure out exactly. No pinpointing of a source. He was prescribed symptomatic treatment with Tylenol, plenty of fluids, rest, everything he did. But his fever continued to the point where he was unable to attend classes. Over the past 1 month since then, he was evaluated at Student Health Service 3 times and has visited actually the ED here 1 time. In his subsequent visit, he was prescribed amoxicillin, clavulanate, augmentin, and Z-Pak because people thought maybe he might have a walking pneumonia, this and that. However, there was no resolution of his symptoms. In his past history, no significant past medical history, really. No surgeries known. His family history is significant for mother and grandmother to have diabetes and hypertension, and social history, sexually active for the last 4 to 5 years, uses protection, 2 to 3 partners so far. On his social history, no pet exposure, no insect bite, no sick contact, very clean history, no recent travel outside of North Carolina. PPD a year back was negative. His medications, basically the ones that we are giving him, no known drug allergy. You do review of systems, the only thing that he has is the ones that I said, except difficulty in swallowing and sore throat and headache. On physical exam also, he had fever, but other than that, really the lymphadenopathy that he had, but other than that, nothing significant. On his blood work, his white cell count was 3,000, as you can see here. Hemoglobin was normal, platelet a little bit low, it looks, but manual differential was huge, atypical lymphocytes. So when you see atypical lymphocytes, by the way, what are the diseases that you should remember? Like CMV, EBV, so that's on the line, so they were really comfortable on that one. So he has mild transaminitis, as you can see here. And blood culture was done, negative. Rapid throat test for flu was also negative. Strep test and also flu test, that was negative. Monospot test was done, that was also negative. EBV viral capsid antigen was done, IgM, that was also with the normal limit. CMV test was done, so that was one of the differential, that was also negative. Chest X-ray was normal. HIV is one of another cause of atypical lymphocytosis, by the way. And they have done the test also, and that was also negative. And the chest X-ray was also normal. So what are you thinking? Huh? So what is it? What is not done? Huh? So HIV RNA, and for what reason? Because, so if it is an acute test, you don't do serology. Serology was done in the clinic, but that was negative. We will come to that one. RPR was negative, Toxo was negative, urine histo was also done for some reason, and that was negative. But his viral load was 632,874 copies per ml. So that was the missing test that was not done. We did it in the clinic. It came to be positive. He was offered to be enrolled in an ongoing study. He has been enrolled in a study for acute HIV treatment. So in his history, when he came back, he admitted that he had actually male-to-male sex partners, and that he didn't give us the story in the up front. So we're going to see into those questions. What are the clinical manifestations of acute HIV? what is the significance of early recognition of primary HIV infection, and what's the impact of PHI in perpetuating the endemics. Because one of the questions that we try to answer is, why is this 50,000 leveling off, it's not going down? So when you see at HIV infection as a primary infection at the early days, the viral load goes up really, really high, because at that time the body doesn't have any kind of immune protection. But within a very short time, the body actually develops an antibody. The most unfortunate thing about HIV is it is not a neutralizing antibody like measles or polio. So it drops the viral load, but it wouldn't drop it to an extent of clearance. Okay, so the viral load will drop down, but it was not. So at this time, when the fight starts, about 4 weeks into the infection, patients actually starts to have symptoms. But the symptom is just a simple viral illness type of symptom, and that lasts actually for a month. So whatever you do, it's going to go away. So if you don't have really that suspicion there, you're going to miss that opportunity. Patients are going to feel fine, and then after the chronic disease process starts. So if that patient is not diagnosed at this time, so he will have an acute an HIV disease with a high viral load, doesn't know that that person is infected, so starts with the immediate close individual, partner infection, but that can go for many, many years, as you can see, until they become symptomatic. So this is where we are missing the boat. So we're going to talk about acute HIV, and as we can see, even though this amount of patients are infected on every year basis, think about each of, how many of you have seen acute HIV infection? Probably one or two. And the reason is because we're missing it. Otherwise, those people are showing up in the clinics, and you'll see whether they are showing up. So there was a study in Swiss, in their court. They went and tried to look into acute infections, acute HIV infections. So what they found out is 87% of the seroconverters actually had symptoms. So it is not because those acute infections are asymptomatic that we are missing them. So that one of the myths is broken here, okay? And 95% of those patients had a medical evaluation. It's not because they are staying at home that we are missing them. They are actually coming to the hospital and being examined. But the problem is a lot of simple diagnosis is being tied to that presentation without the proper diligent workup. And primary HIV was only considered in 5 of the 19 patients that they had on their court, okay? And the remaining patients, even HIV was not considered. So primary HIV often leads to a medical evaluation because of the symptoms, but it is underdiagnosed. So as a resident, as a primary care physician, this is one of the messages that you have to incorporate in your brain. Always when you see those viral illness patients, without any judgment attached to that, HIV test has to be part of your differential diagnosis, and a test that has to be, and that has a significant ramification, as we will see. So the problem with HIV, primary HIV, is because it is non-specific. As you can see, 40 to 90% of patients will be symptomatic, but it is a mononucleosis type of symptom. So when we say mononucleosis type, EBV, CMV, toxoplasma, HIV, acute hepatitis, all of those present almost in the same way. Flu-like symptom, achiness, myalgia, fever, a little bit of headache, and it will resolve over 1 to 4 weeks. After exposure, it starts after 1 to 4 weeks, and it resolves within about a month. A high index of suspicion is very critical, okay? And as you can see, these are the symptoms that you're going to see, and you can relate to those symptoms with many, many viral illnesses, and also acute viral bacterial illnesses. If you look at those also, they can have aseptic meningitis presentation, mild transaminitis, leukopenia, thrombocytopenia can also be the presentations of acute HIV. All those pictures are from acute HIV cases. They can have a very faint maculopapular rash. They can have actually oral ulcers and thrush at the acute disease, but it will resolve. These are very faint rashes, as you can see. Can't even see them from acute HIV infection. This is a soft palate, again, mild rashes, ulcerative lesions in the mouth. Sometimes they might even have a genital ulcer, which looks like almost syphilis. This looks like it was diagnosed as a primary syphilis, but later on found out to be primary HIV. Okay, so when you suspect primary HIV, if that was part of your differential diagnosis, what tests do you do? And that depends on your knowledge about those serologies and the viral tests positivity. So if you look at the HIV RNA, within a couple of days, actually, it turns out to be it turns to be positive. Within a week or so, it becomes positive, and it remains positive for life, even though the viral load might go up and down. Okay, but if you look at the symptoms come after a month or so into infection. So by the time somebody has acute HIV symptom, almost 100% of them will have a positive HIV viral load. So it doesn't matter whether the viral load turns positive after a week or so, but by the time that matters, which is an acute HIV symptoms, almost 100% of them will have an HIV RNA. So if you suspect acute HIV and you do a viral load and the viral load is negative, that is definite diagnostic workup. You don't have acute HIV. So in the past, we used to do P24 antigen as a test for acute infection, and that's a good test, but it's not as good as HIV RNA. What about the traditional tests that we do, serology, ELISA test? Well, ELISA test fails us on that one, because what happens is for ELISA test to be positive, antibodies have to be formed, and that is a process. The virus has to enter into your body, antigen has to be processed, delivered to the host immune system, recognized, a pluripotent prime cell has to be selected, clonal transformation, antibody production, it's a long process. It takes a minimum 2 to 8 weeks for this process to happen. So at that time, the antibody test is negative. Both ELISA test and Western blot test are antibody tests, so they would not be positive. So this is not the test that you would do. So it is more sensitive, the viral load, than antibody, as I said. And the viral load in any way is very high at that time, so you would get that as a positive result. Okay? So the gold standard is ELISA test, obviously. So you do the viral load, you diagnose acute HIV, you do whatever you want to do, but 4 weeks or so after, you have to do the ELISA test and the Western blot test to confirm. But it takes time, as I said. There are two more limitations into our diagnostic armamentarium. One of them is very difficult. Still, we don't bridge it, which is the window period. So window period is basically the time from the day that somebody is infected to the day that these tests are coming to be positive. More and more, as the serology tests are getting better and better, we're narrowing that window, okay? But still, there is a gap. The second one is the time that it takes for these tests actually to be read and the result to be released to you. So if you're an emergency doctor, emergency medicine doctor, you do an HIV test. I mean, the result is coming in a week, in 4 days, in 5 days. By that time, the patient is gone. You can't even read them. That's a big issue. It was a big issue. So now we have actually dealt with that one. There is a rapid HIV diagnostic test. I'm sure many of you have been aware about that. So any delivery center and emergency room actually has to be equipped with those HIV tests. The test is going to be run in 20 minutes. Within 20 minutes, you will get your result. It can be a drop of blood. It looks like a pregnancy test. Or you can actually swab the mucosa of the mouth and do the tests. Very easy to read because there is a control and test bands. And if both of them lights up, you have a positive test. And the concordance, sensitivity, and specificity is above 99%. So these are really good tests that you have to rely on. Why do we care about diagnosing primary HIV? Well, there are two big important reasons. One is for public health reason, for the reason that 50,000 cases are being showing up every day. Because patients with primary HIV are likely to be very infectious, highly infectious, because infection is directly proportional to the viral loads that you have. And then diagnosis of HIV infection leads to safer sex. This is actually not a theory and hope only. There are many studies that have been done on this one. So if people know their serology status, they will be much more cautious. So the likelihood of transmission will actually drop. So on public health point, there are reasons. But on a personal note also, for that specific patient, there are significant ramifications. If you don't diagnose acute HIV, you miss them and they will be in latent disease where there is no symptom. They can last like that for a long time until they become really sick and the CD4 count is 0. And I'm sure many of you have seen newly diagnosed HIV patient in the hospital with a CD4 count of 0 and 10. And these are all patients that shouldn't have been in that position if the acute HIV was diagnosed. And the other very important theoretical benefit is basically if we were to diagnose acute HIV and treat them early, maybe we might actually completely change the paradigm of the virus evolution in their body. I mean, for example, I'm sure you might have been hearing the case for the Mississippi child that they were talking about. This baby, that is a very classic case of where they treat her acutely and they didn't want to stop it, but she stopped and she was lost to follow up. And then after a couple of years when she showed up, the viral load was undetectable and basically it's essentially cured. There are some pointers that has to be addressed there, but just so far it looks like it's almost a cure. And they have really confirmed that the virus was not a transmitted virus from her mom, rather this was actually a virus that was being generated by her own body. So there are ramifications on that aspect also. So as a conclusion for this, primary HIV is underdiagnosed. It may represent a critical opportunity to intervene and to control the new diagnoses. A high index of suspicion is very, very important because the sign symptom is non-specific. And ART might provide an opportunity for improved long-term virologic control of this virus. So this is one side where we can really intervene and maybe even hope to change the paradigm of this constant new diagnosis of HIV. The other side is another, there is another place where we could intervene to actually control this. And that one is about diagnosing those who are in latent phase. So we miss that both, the opportunity in the acute infection phase. Then they become latently infected and they stay like latent. But many of those have been interacting with physicians for years and years, and in those all opportunities, nobody has done an HIV test until they become symptomatic. And the significance is this. If you look at who is the cause of acute HIV infection, you find this kind of graphs. The 21% who are unaware of their infection actually lead to the more than 50% of the new infections, even though they are the minority. While almost 80% of those who are aware are the, this is an epidemiologic study, obviously there are many caveats on this one, but the perception is that the majority of new infection are caused by people who are not aware that they are infected. So how can we intervene to work on this one? So if you look at why people are not being tested or they don't know their status, one of the things is a lot of people don't think that they are at risk. So you ask them, you give them a hypothetical case and they will say, oh, that is a high risk, but they don't think that that is a big risk for them. So that's a big perception gap in humans in general. But doctors also are not very comfortable. Okay? Doctors never recommend it. And there are many studies that show that if a doctor recommends it, there are very few people who will opt out not to be tested. Okay? Actually, people are hoping that doctors will mention that and then they will test them rather than to leave the clinic without being tested. So really think about that. So if you think that that's a way to stem this new diagnostic of HIV, we have to have a change in behavior also as doctors. So missed opportunities for early testing. 73% of late testers had visited a healthcare facility prior to diagnosis, and 80% of those visits were not related to HIV, so they come in for other reasons, but no test was done. So CDC looked into this because for almost 10 years, the new diagnosis remains the same. So, I mean, you can't expect a different result without changing something. So, when they looked into all those, the final decision by CDC, which was communicated in 2006, is basically for anyone between 13 to 64-year age, HIV test screening has to be routine. Okay, so of course, because the most important authority, which is the United States Public Health Task Force, who makes the recommendation on any screening test, didn't agree with CDC still. They only recommend risk-based testing. So what CDC said is this is a matter of state by state. So for us, what matters in North Carolina is the North Carolina legislation has approved it. So North Carolina legislation has said HIV screening test is a routine test. You can do it. So what it gives you is that there's the consent that they give you to treat them at the beginning of when they come into the emergency room is adequate enough for you to do an HIV test. You don't have to have any special consent paper. In our hospital also it is an accepted practice, so you can do that. You don't have to do that. As a physician, you know, as a good practice anyways, when you do something, a test, you just have to discuss that with your patient. That is a routine test. But you don't have to have that elaborate pre-test counseling and then post-test counseling and all those things. You just have to tell them, you know what, as a routine test, HIV test is recommended for everybody. I'm going to do that. Would you agree? They can opt out, okay? If they say no, you can stop that. But almost everybody would not opt out. So once you do that, though, immediately you have to link them to a care. So that is very important, because a lot of times, look at this slide, 28% of patients who have been diagnosed with HIV had a delay in their introduction into care for over 3 months. You see? So that shouldn't happen. So if you're going to do a test, you have to know exactly where to send them. The good thing for you guys, our clinic is open. Any patient you send, within a couple of days, they will be seen in an HIV clinic. But in general, wherever you go, you have to make sure that that is there. So in summary, if we do universal screening, if we do quick screening tests in emergency room and also in delivery rooms, and then really a low threshold for acute HIV infection, we will go a long way in controlling these epidemics in this country. So persons unaware of HIV infection are responsible for a majority of infection, as we said. Earlier testing results in early treatment and higher CD4 cell count, treatment reduced risk of progression to AIDS, obviously a no-brainer there, and so you will have actually an impact on the prevalence. So this was my talk, but I added a couple of slides for you guys, which would be important, because a lot of times the big challenge for residents is actually an HIV patient comes in for diabetes, hypertension, got admitted, they have their medication on board, and you don't know exactly what the interactions are, the side effects, and also even the adverse effects of those medications. So if you look at the broader class-based adverse effects, one of the things that I want you to understand is there is a side effect entity called lactic acidosis and hepatic steatosis, which is caused by all NRTIs. And the reason and significance of this is that if you don't diagnose this, patients can die actually from this side effect. If I was to write a board exam question, these are the kind of things that I would ask, because these are really serious side effects. How do they present? Basically, it's a very non-specific, but they can have abdominal pain, very non-specific things. They can have hepatomegaly, they can have transaminitis, they have lactic acidosis. That is a big thing. So their bicarb is low, their lactic level might be high, and then you look at their HIV medication, they are on those medications, zidovudine, DDI, and D14. And the treatment is you just stop it, and gradually, it takes a long time, but it resolves, okay? A lot of, nowadays we don't use D40 a lot, but that is the one medication that was known to cause lactic acidosis. Tenofovir is the one that is challenged with this renal issue, So if you have a patient who have a high creatinine, low GFR, and they are on tenofovir, that is probably the cause. You might call the ID doctor and discuss that with them. It's not like the acute dehydration related creatinine bumps that we are worried, but persistent gradual increase in creatinine. Okay, but in addition to that, tenofovir is the one that causes bone marrow, bone mineral density problems. So they have osteoporosis, osteopenia. So that is something that you have to worry. So we frequently check for phosphorus and vitamin D levels when they are on tenofovir medication. Zidovudine causes bone marrow suppression, so you can have anemia, you can have thrombocytopenia, and also you can have neutropenia. But in a paradox fashion, if you have an HIV patient, AIDS patient who have thrombocytopenia as caused by secondary to HIV, zidovudine is actually the preferred treatment to reverse that. All NNRTIs cause significant rash. Almost 8 to 10% of patients on NNRTI will develop rash, but few of them will develop rash, which is as worse as probably Stevens-Johnson syndrome. So remember that. Hepatotoxicity also for NNRTI. Efavirenz is teratogenic, so pregnant mothers know efavirenz. And the other thing is neuropsychiatric issues. So efavirenz is a very, very commonly prescribed medication. So these are the side effects that it has. Nevirapine is almost getting out of the market of HIV treatment in this country. So really you don't have to worry because there are very, very few people now on Nevirapine. All PIs, almost all of them pass through cytochrome P450 enzyme. So there's a lot of interaction. Even for an ID doctor, it's just mind-boggling. But the things that you have to remember are hyperlipidemia. So if you have a patient on a really high cholesterol, a significant cardiac risk factor, risk history, maybe if it's possible, they shouldn't be on PIs, if possible. If so, maybe you might be adding cholesterol medications in early stage. So insulin resistance and hyperglycemia has been noticed with many of the HIV medications. So think about that one also. The mechanism is not very well understood, but it is just basically insulin resistance like type 2 diabetes. Another one is hyperlipidemia. Obviously, Kaletra, for example, one of the PIs, is very well known to cause a high cholesterol, LDL and total cholesterol. Ritonavir is also another one. Ritonavir is very commonly prescribed. As you know, nowadays there is no HIV patient who takes ritonavir as an HIV treatment. If you see ritonavir, it is just there to boost the other PI. So we call it a booster. So it doesn't even count as an HIV medication, don't count it. But because of that, almost every PI that is given for HIV patient is given together with ritonavir, which causes this. And also, those PIs cause hypertriglyceridemia separately. What else? So these are the big side effects. This bone marrow abnormality is a big deal. A lot of HIV patients actually develop avascular necrosis of the hip. We really don't know exactly the mechanism, but PIs are the ones that are really incriminated for that. But osteoporosis and osteopenia can happen in many of the other medications also, including NRTIs like zidovudine and AZT, and also tenofovir. So this one, I think we mentioned that. Nephrotoxicity. One of the other things that board exams like is the nephrolithiasis from indinavir, but indinavir is not used anymore as much as it used to be. So the only one that they might ask you is atazanavir. Atazanavir also might crystallize in urine and cause exactly the same. Basically, it's a kidney stone, basically the same symptoms as kidney stone. So the drug interactions are mainly with PI. Remember that it is because of the cytochrome P450 enzyme passage of those medications. So there are a lot of drug adjustments. So really, it is so complex, it's better to communicate with the HIV doctor. But just remember that when you add medications like rifampin, seizure medications, um, uh, uh, those are the medications that you have to really be aware about. Another very important interaction that I want you to remember is about atazanavir and proton pump inhibitors. So, I mean, in your clinic, you just add proton pump inhibitors, I mean, without any thinking, as long as they need it of the other interaction. But atazanavir is proton pump inhibitors actually are contraindicated for with atazanavir. So just they decrease significantly the level. So you really have to know about that. If it's A2 receptor antagonists, you can create a gap of time and give those medications. Okay, so basically these are all classes of medications that have to pass either inhibit or activate cytochrome P450 enzyme, and there might be some interaction with that. And that's it. The last part of side effect, actually, I just added it because a lot of times people ask of those questions, but that was not part of the discussion. Do you have any question? Go ahead. So viral load for few things. For example, there is a medication called Complera. It is a combination of 3 medications in one pill. So if you want to give that, you can't give it if the viral load is above 100,000. So that's kind of recommendation. But by and large, viral load and CD4 count are not the main reasons on making decision on which one to choose. It's actually the other comorbid conditions more than anything else. And in addition to that, adherence to medication. So pregnancy, the prospect of pregnancy in the horizon, and all those things. So a lot of times we try to make it as simple as possible at the beginning. So I will say I don't have an exact number, but I'm sure more than 60–70% of those newly diagnosed HIV patients will be started on 1 pill a day, okay? Just 1 pill a day. Because there are 3 choices that you can do that. Atripla is 1 pill a day, Complera is 1 pill a day, and Stribild is 1 pill a day, okay? So because they combine those, so for ease, and they are as effective as any other combination you can imagine. So that will be the way how we would start. But immediately, when you have co-infected with hepatitis B, co-infected with hepatitis C, diabetes, hypercholesterolemia, significant family history of cardiac disease, then those choices have to be remodified again. And starting a new patient is not very difficult, by the way. You just can throw a dart in any of those combinations and they will do fine. It's such a good, potent medication, you would not be wrong in any of those combinations. The problem is when they fail, how do you follow them? When do you change medication? And then when they fail this regimen, which regimen should be the one that you start? That is when the things become tricky a little bit, because you have to see the mutations. Oh, is that right? Okay, then let's stop. I thought it was until 2. Okay, so let's stop. If you have any question, we can do it outside. Well, you